Yeah, I think, it's a difficult time when patients get to the end of a phase of treatment and move on to a different phase of treatment. And ovarian cancer is not one of those cancers where it is entirely treated surgically or it's entirely treated by one modality. And that carries with it a sort of inherent uncertainty, or there are periods of uncertainty where transfer of a patient between teams can be a functional process that doesn't always take into consideration that feeling of anxiety and uncertainty that the patient might have. And I think we do quite well in signposting patients about what's going to happen and giving them the support through the clinical nurse specialist team as a point of contact. And personally, I always say to patients, look, this is a time that it might feel a bit scary because you're changing people. There are different people taking over responsibility for your care. But if you feel lost, these are the people you call.
We don't receive any correspondence from medical oncology. So often when we're contacting patients who might be on our caseload, you're actually ringing them for as much of an update as to where they are and what's happening. We do now have access to Gateshead patient record on Medway, so you can see letters from other hospitals. So that has improved things. Probably correspondence from medical oncology would definitely, I think, improve or probably make our life better. It's not going to impact that much on the patient. The one thing that's difficult is that the patients have quite complex pathways as such in terms of who the nurse specialist is. So if a patient comes to us from, say, North Tyneside, their nurse specialist might be Susan Richardson. Then they come to us and one of us would pick that patient up for their inpatient experience, and usually for a week or two after discharge we might maintain some contact, but then we would send that patient back to the local nurse specialist. And I'm not entirely confident sometimes how much people keep in touch with the patient, so we will often end up in a rescue situation because the patient will say, I don't know who to ring anymore. Often because they've had what they see as their treatment here, they'll contact us, and that can be hard because our patient caseload can be huge. And obviously the bigger it is, the harder it is to then offer the level of support that each of those women needs. And I'm not sure what we could do to articulate or to communicate that to women. I think when they have regular contact with a nurse specialist, it does smooth the pathway and they've just got somebody to ring if they've got worries or concerns about anything.
It's a hard one because you try to prepare patients. Again, you give them your details. And then, we tend to keep the Gateshead patients, but the rest of the patients go off and you hand them over to other CNSs. We try to do a holistic needs assessment at the end of the treatments for the Gateshead patients, but not for the other patients because that's down to their local CNSs. You try to sometimes discharge patients back to the local CNSs, but you build up a rapport and then they'll ring you. It's sometimes hard because then they may have, if they've had the surgery here, they know us, they've seen us, they've spoken to us a number of times, and they rely on us, and they'll not contact the local CNS, or they've tried to, and they haven't, nobody's been there. And again, that's probably due to the pressures that's going on. Some patients, I think, feel when they finish the treatment lost, because I've had that many appointments and seen different people. When we do the holistic needs assessment, we do the end of treatment summaries, which I think is fantastic because then you've got your, that should help when they go into primary care. So they're doing the cancer care reviews, the GPs, hopefully that'll help people who are in primary care, as well as the patient, because the patient should get an end of treatment summary as well, what to look out for, but also consequences of treatment, so they know when to give us a ring. So, and it's personalising that care to them as well. Personalised care, very important. And yes, we'll give, they get information, they've got the charities there, but actually it's about that personalised care. So doing the end of treatment summaries, having the end of treatment holistic needs assessment is really important, and it's setting it so that they understand what's going to happen over the next couple of months. They've been that busy and they haven't had, they've had a lot of contact, shall I say, and then suddenly there's no contact, no hospital visits, and that can be scary for people. But preparing them that things will change because of the treatments. Some people go to early menopause and don't recognise what the symptoms are.
But I think when you go back into the community, I feel like I perceive a big void, and that I think we would want to be doing a lot more for women to help them get back on their feet and rehabilitate them. And there's evidence to say that if you like with chest diseases where they do rehabilitation, that there should be something like that available to our ladies as well, to get them back on their feet and get them back to normality. We always underestimate the psychosexual effects of undergoing treatment for ovarian cancer, and I think there are some services available, and I think some of our nurse specialists are exceptionally good at talking about those kind of matters. But I still think we've got a long way to go to effectively treat women for the after effects of all of this treatment. I think we're very good at getting results to people in a timely manner. I think the team at the QE work very quickly to get those diagnoses, and certainly that's reflected in other places where I've worked before. I think we're pretty quick. In terms of follow-up, I guess the capacity we've got to follow women up is quite variable, particularly at the moment when we're dealing with a backlog of follow-up for patients. And a lot of the work that's been done with some of our nurse specialists here at the QE for patients to drive that follow-up and contact is quite helpful. But again, I think for some women that's not the right approach to take, and I think more dedicated follow-up for them, for those patients, is much better.